Professor Chanson from Paris, thank you so much for giving us a couple of minutes.
It's a pleasure.
You've been talking today about acromegaly, about treatments, and particularly Cabergoline.
Yeah.
Because it's been around a long time, people not completely convinced of how to use it or whether it's worthwhile. Would you like to tell us all about it?
Yes, Cabergoline is an old drug which is mainly used in hyperprolactinemia and which works very well. But in acromegaly, it has never been approved. But it was tried before the era of somatostatin analogues. Yeah. And so there has been an experience, but people have been a little bit disappointed with this drug by trying them. And there has been very few studies about that. And so when we talk about the strategy of treatment in acromegaly, we always put Cabergoline, but we don't know exactly the place the drug has, and so that's the reason why we try to have this systematic review and meta-analysis in order to know a little bit more about the effect of the drug.
And there are no randomized trials of this drug
No,
either.
randomized trials.
Astonishing.
No.
Yeah.
No, I think that the industry never push the drug in that indication, and I think that the advent of somatostatin analogs has also completely changed the scenario. So that's the reason why.
So what did the meta-analysis show us?
So the meta-analysis shows us that, in fact, about 1/3 of the patients treated with Cabergoline as single-agent therapy normalized IGF-1 levels. So it's not so bad. And but probably the effect is better in the patients with not very active disease, moderately active disease. This was our impression before, but I think that this gives good arguments. And the other part of the meta-analysis shows that when patients have not been normalized in terms of IGF-1 levels with somatostatin analogs, when we had Cabergoline, we can achieve normalization of IGF-1 in half of the patients. So it's second-line treatment, medical treatment, which may be interesting and cheaper than somatostatin analogs.
Sure. Well, it's off patent, presumably.
Yeah.
Yeah. Sure. So just let me get this clear: somatostatin analogs, and there are several around, and a nice new one presented here. When they fail, or if they fail, you can continue on those and add in Cabergoline. That would be the strategy, because of course you have two different mechanisms. Right?
Yeah. In fact, in the majority of patients, there is an effect of somatostatin analogs. They are not totally resistant.
No.
And so in some patients, in half, I don't know if it's the true proportion, but it brings normalization of IGF-1 levels when the IGF-1 levels had sufficiently decreased. So it's interesting to add it.
And it doesn't add toxicity?
So that's one of the points we have to look for. This has not been looked for in acromegaly, but obviously you know that there have been some concern with all the ergot derivatives for Parkinson's disease, using high doses with valvular disease. It seems that in hyperprolactinemia, even with high doses of dopamine agonists, and particularly with Cabergoline, there's no valvular heart disease apparition. But we have to look at that in acromegaly, because patients with acromegaly have already heart disease, cardiomyopathy, and we know that they have also an increased prevalence of valvular disease even before any treatment. And so I think that we have to balance this potential risk with the benefit. But probably in many patients with acromegaly, we need different treatment in order to achieve good results. And so the combination of different drugs, even those, and why not also a GH receptor antagonist in order to achieve the best results may be interesting.
Professor Chanson, thank you very much indeed. I appreciate it.
Thank you.
Thank you.
Thank you.